Okay, can everyone hear me here and on Zoom, I hope as well? Wonderful. Well, it is so great to see those of you who are here today with us in person. I don't know when that's going to stop being so exciting, but it's sure still exciting for me to actually see other human beings. And I'm also delighted to welcome the more than 30 people who are joining us by Zoom today as well. So welcome everyone. Those of you who are on Zoom, if you have questions during the talk or after the talk, please put them in the chat, and Esmeralda will make sure that we're aware of them in the room here. So I have the pleasure of introducing our speaker for today, Professor Kari White. Kari is an associate professor in the Steve Hicks School of Social Work at the University of Texas at Austin. She also has a joint appointment in the Sociology department there and is a faculty research affiliate at the Population Research Center. Kari received her PhD in sociology with a concentration in demography from the University of Texas at Austin, so recently returning home to her home institution. She also earned an MPH from Tulane and an MA in Latin American Studies from the University of Arizona. Kari's research focuses on the interrelationships among reproductive health behaviors and outcomes and the health services and policies that shape access to care. She's got a number of really exciting recent and ongoing projects, including the Texas Policy Evaluation Project, which is a collaborative evaluation of legislation affecting family planning funding and abortion restrictions in Texas. She also studies factors influencing vasectomy use and women's access to abortion and post-abortion contraception in the Southeast. The exceptional high quality and impact of her work was recently recognized by an Early Achievement Award from the Population Association of America in 2020, which puts Kari in excellent company, including our former CCPR graduate student, Jenna Nobles, and our current CCPR faculty member, Hiram Belchen Sanchez. Today, Kari is going to be discussing a topic that really couldn't be any more timely, the impact of abortion restrictions in her home state of Texas. So with no further ado, I will turn the floor over to Kari. Welcome.
Great, thank you. Okay, so I'm going to take my mask off here. Is it okay if I just make this window small? Is that fine? Okay, great. Well, thanks everyone for joining virtually and here in person. As Dr. Sweeney said, I'm going to be talking about some of the research my colleagues and I have been doing in Texas, looking at the impact of abortion restrictions in that state, largely state level restrictions on abortion. Just by way of background, the Texas Policy Evaluation Project began in 2011 to look at some of the very dramatic changes that the state of Texas had put in place related to funding for contraception, as well as abortion restrictions. And we have continued to do this work over the last 11 to 12 years, because frankly, there has been no end of work to do. So I will just jump right in here. Oops. And first want to recognize our amazing collaborators, doctoral students, postdoctoral fellows, clinicians, both in Texas and outside of the state. Without their many contributions, none of this work would have been possible. So I just want to provide a little bit of context on what abortion policy in the state of Texas has looked like over the last several years. The Texas legislature is unusual in the fact that it only meets every 2 years. But it does a lot during the time when it is in session. And the legislature has passed restrictions on abortion in every session for the last 10 years. Some of the policies that are really relevant to people's access to abortion care include a mandatory ultrasound that is required at least 24 hours before someone obtains an abortion. And that ultrasound must be provided by the same physician who will carry out the abortion. So this requires someone to make 2 in-person visits to a clinic. This is not medically necessary, but is required by the state of Texas. The state also has passed a variety of restrictions on coverage for abortion in private insurance plans, marketplace plans, as well as Medicaid. And there are very few exceptions that allow coverage through insurance. Minors also have to obtain parental consent before they can get an abortion or have a court hearing in their county of residence and obtain permission from a judge. The state also has prohibited the provision of medication abortion through telemedicine or by medications being shipped through the mail. And the state also has prohibited dilation and evacuation procedures, which is the standard procedure for providing abortions after about 15 or 16 weeks of pregnancy. And abortions before fetal viability are prohibited. And I'll get into a little bit more information about that in just a minute, because those policies have changed recently. So what does the abortion service context look like in Texas? There are currently about 22 facilities that provide abortion care in the state, and these are primarily located in Texas's major metropolitan areas. And this is about half the number of facilities than there were 10 years ago when services were available in smaller cities. And you'll see a little bit more about this in just a minute. But as you can see, there are enormous areas of this very large state where there are absolutely no providers of abortion care. So our work related to evaluating abortion restriction really got into full swing in 2013 when the state of Texas passed House Bill 2, or HB 2, which was an omnibus restrictions bill. This was actually proposed during the regular legislative session. It did not make it out of to the governor's desk. And so then Governor Rick Perry called 2 special sessions in order to get this law passed. And this image here on the right-hand side of your screen is a picture of supporters of abortion rights filling up the Capitol during the first legislative session when then State Senator Wendy Davis gave a filibuster to try to keep the law from going into effect. To keep the law from being passed. It did unfortunately pass in the second special session that the governor called. And the law had 4 main provisions, which I have listed here. It required providers to have admitting privileges at a hospital within 30 miles of the place that they provided abortion care, which is not necessarily going to reduce or limit any emergency care that someone might need in the rare event that that happens. The state also restricted the provision of medication abortion and required providers to follow an outdated protocol that was no longer consistent with evidence-based practice. Texas also banned abortions after about 22 weeks of pregnancy or 22 weeks of gestation. And it required all abortions to be provided at ambulatory surgical centers, or ASCs, which have specific requirements around anesthesia, nursing staffing, the width of hallways and corridors, none of which are really applicable to the way that abortion care is typically delivered. So these first 3 provisions that I have listed here on the slide were set to go into effect in November of 2013, and then the ambulatory surgical center requirement would go into effect a year later to give facilities time to come into compliance with that requirement. So what did we, ultimately what happened with this law is that about 3 years later, the US Supreme Court struck down the hospital admitting privileges requirement and the ambulatory surgical centers requirement. And when Justice Breyer issued his decision, he very clearly saw that there was no threat to women's health that these laws were going to address, and that instead Texas was putting women, the language that he used, in a position where they had to travel long distances to get abortions in crammed to capacity super facilities and not getting the kind of individualized attention and support that doctors at less tax facilities might have offered. And this decision in Whole Woman's Health versus Hellerstedt, for at least a brief moment, set a new standard by which abortion restrictions needed to be evaluated by state, appellate, and the Supreme Court. But as we know, that circumstance has changed. So our team started looking at the impacts of HB2 in a variety of ways. One of the things that we started doing was conducting monthly mystery calls to all in-state facilities in order to document whether or not they were providing services at all, because some places may not have been able to secure hospital admitting privileges for one of the physicians that worked at their sites, whether they offered medication abortion to people who were within the much narrower gestational limit for that type of abortion, and also how long it was taking for people to get in for that mandatory consultation visit. We also have analyzed abortion facility volume, that we obtain that information directly from clinics. We've conducted surveys and in-depth interviews with people at abortion facilities. And we have also analyzed aggregate and individual level state vital statistics data. And so I'm going to highlight some of our key findings from this work, just to give you a sense of how we have gone about looking at these restrictions, and then I'll fast forward a bit to what we're seeing in Texas today. So one of the things that we tracked through our mystery calls, and as I alluded to earlier, is that the number of abortion facilities in Texas decreased by half. So you can see in this left-hand map, this is where abortion facilities were located before HB 2 went into effect. So while there were certainly areas of the state, like in the corner of Northeast Texas or at the very top of the Texas Panhandle, north of Lubbock, that did not have an abortion facility, there were still quite a few facilities across the state in smaller communities like Kylene, San Angelo, Midland, and Lubbock. But after the admitting privileges requirement specifically went into effect, far few facilities were offering abortion care. And again, these were concentrated in the major metropolitan areas. So what this means is that the distance to the nearest US abortion providing facility increased dramatically, which you can see here comparing these two maps. So the darker color of purple, hopefully that's what it looks like to you, but that's what it's, that was the color we chose. Those darker colors of purple reflect greater distances to care. And so you can see in very South Texas along the US-Mexico border, as well as vast areas of West Texas and the Texas Panhandle, many Texas counties were 100 miles or more from the nearest facility that provided abortion. So with fewer facilities providing abortion, what we also learned through our monthly mystery calls was that the waiting time until the next consultation visit increased. But this increase was different across the different metropolitan areas, again, reflective of both the number of facilities that were providing care, as well as the number of physicians who were staffed in those facilities in order to deliver that care. So Dallas, which is that top solid blue line, had the highest waiting times in the months immediately following the implementation of House Bill 2, where people were waiting 2 weeks or more on average to get their first consultation visit. So they would still have to return a second time in order to be able to get their abortion. And that was because there were fewer facilities in the Dallas metropolitan area that were providing abortions during that time period. In contrast, Houston, and El Paso, which are shown by those two lines at the bottom, had fewer disruptions in the facility and provider network. And so they had wait times that were typically about 2 days on average for someone to get in for that mandatory consultation visit. And if someone has to wait 2 weeks or more in order to get their abortion, this is, by simple mathematics, going to push people a little bit later into pregnancy. This is going to mean that people who may have been eligible for medication abortion at that much narrower gestational limit, which at that time was 7 weeks of pregnancy, would very quickly no longer be eligible for that method, and they would have to get a procedure abortion, which is very safe, but not necessarily the method that some people prefer. It also means that someone may be pushed from getting an abortion in the first trimester of pregnancy to getting an abortion in the second trimester of pregnancy, or later in the second trimester of pregnancy, when there are fewer providers that deliver that type of service. It can be more expensive to people. And so there are real health implications for wait times of 2 weeks or longer. And so not surprisingly, with fewer facilities providing care, longer wait times, we saw by collecting data directly from abortion providing facilities that the number of abortions in Texas decreased by about 13% in this period of November to April 2014 compared to 1 year before. And we really wanted to do this kind of period to period comparison because of the known seasonality in pregnancy, which similarly is reflected in abortions as well when people get abortions. So we really felt like it was important to compare these two time points, which I will return to a little bit later in the talk. We were also able to obtain individual level data from the state, the Department of State Health Services on the individual records of people who have obtained an abortion in the state. So like many states, I'm not exactly sure what the procedures are in California because California has different kinds of reporting around abortion, but in many US states, any provider who provides an abortion needs to fill out a form that gets submitted to the State Vital Statistics Office that just reports some very basic information depending on your state. Some states require a lot more invasive information, but certainly what type of abortion the person had, how far along they were in their pregnancy, age, race, ethnicity, which is not often captured very well, and a couple of other pieces of information. So we were able to get information on, as you can see here, tens of thousands of Texas resident abortions that were provided in the state. And what we found is that comparing the period before House Bill 2 went into effect to the period after House Bill 2 went into effect, both the number and the percentage of abortions that were provided in the second trimester of pregnancy increased. We also looked at how indicators of access to services, as well as this policy effect, were associated with second trimester abortion. And what we found is first, looking at just the time effect, implementation of the policy, we found that indeed this was a real association that the proportion of abortions that were provided in the second trimester of pregnancy increased in the period after the law was in effect. But looking at the results from Model 2, you see that after we controlled for other indicators of access, including distance to a facility, the demand for services in terms of number of women per facility, we saw that this period effect decreased, but was still significant. But these indicators of access explained a substantial share of the effect of the policy. And we also saw, perhaps not surprisingly, that as distance to a facility increased, especially for people who were living 50 to 99 miles from the nearest facility that provided abortions, the share of those abortions that occurred in the second trimester of pregnancy was greater. And there was also a higher odds of having an abortion in the second trimester of pregnancy for people who lived in areas of the state where there were fewer facilities providing care. So this is clearly reflective of the fact that access to services, or more limited access to services, we should say, are associated with having an abortion later in pregnancy. We also worked we also obtained data from state health departments in states that surrounded Texas and obtained data directly from clinics in other states surrounding Texas in order to get information on how many Texas residents went out of state to get their abortion after House Bill 2 went into effect. And so you can see the time trends here. So first of all, just for the data nerds, you can see some of the seasonality in abortion here, with higher numbers of abortions occurring in February relative to other periods of the year. But you can also see, more importantly, the jump in the number of people getting abortions out of state. Here we collected data from New Mexico, Oklahoma, Louisiana, and Arkansas. And you can see this, that the number of Texas residents getting their abortions out of state doubled after the law went into effect, remained high in the period that the law remained in effect, and then began to decrease somewhat after the Supreme Court issued their decision in the end of June of 2016, which is represented by that third dashed line a little bit further on the right-hand side of your screen. So we also looked at this rather than just, kind of eyeballing the map, which is this graph, which is compelling of its own. We also ran a series of interrupted time series analyses to model these trends in out-of-state abortions. And what we found is in our first model that just looked at implementation of the law, that there was indeed more than twice as many Texas out-of-state abortions following implementation of House Bill 2 compared to the period before. But we also saw a decrease, again, in the number of abortions that Texas residents obtained out of state after the Supreme Court decision was issued. I don't think I have this highlighted, but as you can see in that bottom cell there, that there was also a downward trend, a slight downward trend in the number of out-of-state abortions following the Supreme Court decision. So we see this as really compelling policy evidence that when you restrict in-state abortions, at least some Texas residents are going to travel out of state. But just kind of keep in the back of your mind this twice as many Texans going out of state after HB2, because I'll return to this in just a minute. So one of the things that had been kind of challenging for us in doing this research, and I think for a lot of researchers, is that really this universe of data that we would really love to have access to, that the many state health departments collect, there's a delay in when these data are typically released. And up until 2014 or 2015 or 2016, there is usually a delay of about a year or 2 years before these vital statistics data were available, just usual practice, right? So the 2014 data that really would have shown the full 1 year impact of House Bill 2 was expected to be released in spring of 2016. Spring 2016 came, spring 2016 went, and there were still no data on the number of abortions in Texas that the state health department made available on its website. And in the days leading up to the Supreme Court decision, a reporter at the Texas Tribune published this story indicating that the data were ready and the state was not releasing them because it was clearly going to show something contrary to the state's arguments, which was that abortions shouldn't decrease with this law, that this law was just there to make abortion safer. It's not going to affect the number of abortions or create an undue burden on Texas residents needing abortions, and therefore this law should be constitutional. What we found later, when the data were released, 3 days after the Supreme Court issued its decision ruling the Texas law unconstitutional, was that indeed the number of abortions decreased in the way that we had predicted, just looking at the data we obtained directly from abortion facilities in Texas, but that these decreases in abortion were clearly associated with changes in distance to an abortion provider. So as the distance to a facility increased, the number of abortions decreased. So in counties that had at least one facility providing abortion care, so again, that would be Dallas, Fort Worth, Harris County, where Houston is, there was a decrease in the number of abortions, about a 15% decrease. But there was this very clear linear trend and the decrease in abortions with greater increases in distance to care. And again, those changes were most pronounced in the Texas Panhandle and West Texas and in the very south of Texas, where abortion facilities had closed and distances were far greater, of course. So because of this very long and seemingly political delay in the state releasing the vital statistics data on the number of abortions, folks on our team worked closely with abortion providers in Texas to set up essentially a parallel reporting system where those facilities would send to us aggregate totals of the number and type of abortions that they provided on a monthly basis. So we reach out to them every month, asking them for the number and type of abortions that they provided in the month before, and they send that information back to us. So the majority of abortion providers in Texas do participate in this kind of parallel reporting process. And these facilities account for over 90% of all of the abortions that are provided in the state when we compare our numbers with those from the state of Texas. So we may not have the same count, but we can often see the same trends. And I'll get back to this again in a minute. And I have real time here in quotes because as much as we like this to be real time, it isn't always. Yes.
So there's a question in the chat from Nathan Hoffman, and his question is, are there any estimates of illegal abortions, those that do not take place in abortion facilities, and how numbers of those may have changed in the wake of abortion restrictions?
Yes, can we return to that at the end? Because I think that's going to be really relevant to some of the other information that I talk about with respect to the new abortion law. So just remind me and I will get back to that. But the answer is kind of, sort of. Anyway, so real time, as much as we would like this to be real time, people have obligations at their job beyond just reporting these numbers to us. And so oftentimes, we get a couple months of data at a time versus every single month, but it still allows us to kind of track in a very timely fashion what's happening with abortion in Texas. And so a couple of examples of this that I'll highlight is that in 2016, in kind of an unprecedented move, the Food and Drug Administration updated its label for mifepristone, which is one of the drugs used in the medication abortion regimen, to be more consistent with evidence-based practice. And this had the effect of nullifying Texas's restriction on medication abortion. And so because of our kind of parallel reporting system, we were able to see that there was this decrease in the number and share of abortions that were medication abortions when when HB2, getting ahead of myself, was in effect, which is represented by that middle bar. And after the FDA label change, we saw that both the number and percentage of abortions that were medication abortions increased again because providers could now start offering these medications to a later gestation in pregnancy. We were also able to use this kind of parallel reporting system to track what happened in March 2020 when then Governor, well, he's still the governor, but no longer Rick Perry, now Governor Greg Abbott, issued an executive order that postponed surgeries and procedures that were not considered to be immediately medically necessary. And the Attorney General, Ken Paxton, interpreted this to also include abortions. So we were able to use this reporting system to show how abortions changed in Texas when this executive order was issued and how it changed relative to the same month the prior year. So in March and April, we saw notable decreases in the number of abortions that were provided in Texas, with the most pronounced decrease being in April, which was when the executive order was in place for most of that month. We also saw that any abortions that took place were largely medication abortions because of a very complicated series of court opinions that allowed some medication abortions to be provided. And because people couldn't get abortions in Texas in many places at this time and had to wait, we also saw a 61% increase in the number of abortions that were provided in the second trimester of pregnancy. Again, being able to show that these types of restrictions on abortion are pushing people later in pregnancy when they get care. So fast forward to 2021, when the Texas legislature passed Senate Bill 8. This is a law that prohibits abortions at the onset of embryonic cardiac activity, which is about 6 weeks of pregnancy. It's often referred to as a 6-week ban or a heartbeat bill. Neither of those are really medically accurate. But the point is that it prohibits abortions very early in pregnancy. The law only allows exceptions for medical emergencies, but not rape, incest, or fetal anomalies. And it also includes, as many of you have probably heard, this unique provision which allows almost anyone to sue a person who provides or aids and abets an abortion in Texas after embryonic cardiac activity is detected. So unlike prior restrictions, which were enforced by state health departments or other arms of the state, this is a law that is enforced by private citizens. And it was a law because of this 6-week ban component that many people thought was never going to go into effect. Other states had passed 6-week bans. They have been found to be unconstitutional. And so many folks, including people on our team, and I will count myself in that group, thought that there's no way we have to be worried about this law. It is so blatantly unconstitutional, it's ridiculous. This is just a waste of time and a way to score political points. But as after the law was signed a year ago tomorrow, and legal challenges began to move through the courts, it became clear that this private enforcement mechanism was going to make it very challenging to block the law from going into effect. And so if someone was unable to get their abortion in Texas before about 6 weeks of pregnancy, they were going to face incredibly long travel distances, which you can see here on this slide. The majority of Texas's 254 counties were 200 or more miles away from the nearest facility that provides abortions. So we had some data that we were sitting on, a relatively recent survey at the time of people who had obtained their abortions at one of 12 facilities in Texas. And so we thought, hey, we're going to look at our survey data and see how many people are likely to be affected by this law. And what we found is that about 58% of people were less than 6 weeks of pregnancy when they first contacted the clinic where they obtained care. But by the time they went through the mandatory ultrasound and waiting period and returned to their clinic for their abortion, just 16% were still less than 6 weeks of pregnancy. So we were anticipating that this law was really going to shut off access for the vast majority of people in Texas. So we worked quickly over the summer to come up with a couple of different ways to look at the impact of SB 8. We were able to use our kind of parallel reporting system to document changes in the number of abortions that were provided in Texas. We reached out again to our colleagues at facilities in neighboring states to see if they would be able to track the number of Texas residents who were going to their clinics for care. We did interviews with Texans who obtained services out of state and also did a survey of people seeking abortion services. We've continued to conduct our mystery calls to in-state clinics, but also expanded to surrounding states. And we've also interviewed clinicians about how this law has impacted their practice. So what has happened so far? Well, because we had this close to real-time monitoring system, we were able to document and worked with the New York Times to publish a story that the number of abortions in Texas fell by half in the first 30 days that the law was in effect, compared to the same month the previous year, so September 2020. This 50% decrease that we reported in October of 2021 mirrored the 50% decrease that was eventually reported by the state in February of 2022. We have also continued to track the number of abortions that are being provided in Texas, and we haven't really seen any additional significant downward trend in the number of in-state abortions. So abortions have fallen, they've stayed low, but they're not continuing to decrease. And we haven't identified any facilities that have closed or have stopped providing abortion care. We've also, as I mentioned, are tracking Texans getting out of state care, and we have received data, not quite on a monthly basis, but close enough, from facilities in 7 states: Arkansas, Colorado, Kansas, Louisiana, Mississippi, New Mexico, and Oklahoma. We've received data from the majority of facilities in those states, and in 6 of the 7 states, we have data from all or most of the abortion providers. And what we have seen comparing the number of Texans who went out of state between September and December 2021 to the most recent year of data that we had available for the same time period, we saw that nearly 5,600 Texans received an abortion out of state. This is 10 times what we have seen in the previous period. This is greater than what we saw when half of Texas abortion facilities closed following the 2013 implementation of House Bill 2. We also tracked this with the executive order, and this number far exceeds what we saw during that 30-day period when Texans went out of state because abortions were inaccessible during that order period. And we have seen that on average, about 1,400 Texans traveled out of state each month, and nearly 3/4 of them have gone to just 2 states. Most to Oklahoma, which has passed new restrictions that will be prohibiting abortion, and about 1/4 to New Mexico. All of these facilities, with the exception of Colorado, have far fewer clinics that provide abortion care than Texas. They also have much smaller populations. And so this is putting a huge burden on these facilities. What we have seen from our mystery calls is that over the months that SB 8 has been in effect, this is just data through January, that the waiting time to get in for a first visit at these facilities has increased. By January of 2022, at many facilities, the wait was at least 2 weeks, sometimes 3 weeks before people could get in for their first visit. In some facilities, though, we have those little stars there in the table. In some states, at least one facility just wasn't scheduling appointments because they were booked out too far, or we weren't able to get through after multiple attempts because there was such a huge demand for appointments. We have heard from our colleagues in these facilities, they have had to buy new phone systems to be able to handle the call volume coming in, that they are getting sometimes 200 calls in 2 hours from people trying to schedule appointments. So there has really been, when you have the entire Dallas-Fort Worth metropolitan area trying to get abortion care in Oklahoma or New Mexico, that's really going to put an immense demand on just the 4 facilities or 5 facilities that are in the neighboring states. So some other early impacts that we have documented or that our colleagues have documented. Amanda Stevenson, who's at the University of Colorado and at Boulder and used to work with us, did a very quick look and tweet on what happened with minors. And she found that the number of minors who got abortions in that first month that SB 8 was in effect was far lower than in previous years, and that the percent decrease for minors was far greater than for people in older age groups. So this group is clearly not getting access to care. We've also seen from the data that the out-of-state facilities are reporting to us that there is, not surprisingly, an increase in the number of abortions or the share of abortions they're providing at 12 weeks of gestation or later. So these, again, are cases that patients that need more time in the clinic. These are going to be more costly for patients to pay for out of pocket because those very early abortions are either being provided at Texas clinics or, and I can address this in the Q&A, people are ordering medications online. So I know I'm getting short on time, so I'll move through these last pieces a little more quickly. We've also done in-depth interviews with people that we recruited in the 7 states. We were able to interview 65 participants between October 2021 and February 2022 about their experiences getting care out of state. Some of the things that we have learned from them is about how they make their decision about where to go for care. Not surprisingly, when that next appointment is available is very important. Also, how far it is from where they live, whether or not they were referred or went to like a sibling clinic, so a clinic in Texas that has another clinic in a different state. But people are also considering waiting periods, cost, whether or not people they know are in the area. But even though people are making, taking a lot of factors into account in deciding on where to go, they aren't always able to take that most important piece. What is most important to them isn't always possible. So you can see in this first quote from a 21-year-old Black college student, Louisiana was the closest clinic. It was only 6 hours away compared to some of the other facilities, which were 7 hours away. But they weren't able to get in the Louisiana clinic, and so had to go to Wichita, Kansas to get their abortion. Some people, again, deciding to go to New Mexico because they have very few restrictions, and that would help them with their childcare responsibilities. Other people need to figure out where to go, as in this last quote, because of gestational limits on when providers are able to, the point at which they are no longer able to offer abortion care. And I'll get back to that in just a second. And even though we have seen a large number of Texans go out of state to get their abortions, I think it's really important to remember that this is coming at an incredible cost to people, a psychic cost, a social cost, and an economic cost, as you can see here. People are delaying multiple payments on regular bills, internet, car insurance, truck payments, credit cards. They learn that their insurance isn't going to cover it, even if they're going to a state where it's not prohibited. They can't feed their families. And as this last quote represents, people are literally looking for money around the house, scrambling change together in order to help pay some of their cost to cover traveling out of state and paying for care. So it is an incredible strain on people traveling right now under these circumstances, which are likely to get worse. As I mentioned, we have also done, in addition to these doing interviews with people who went out of state for care, we're also interviewing providers. And we have heard consistently in both of those sets of interviews that Texas providers are afraid to intervene in cases where intervention should be really obvious. So this is, quote up here is from a person who had a premature rupture of membranes at 19 weeks of pregnancy. This can be life-threatening. You can experience hemorrhagic bleeding, develop sepsis if the pregnancy isn't terminated. And her physicians were so afraid to intervene that they told her that she needed to go out of state, which was very dangerous. And she had to face either driving through West Texas, where there's very little health care, or getting on a plane and flying to Colorado. And what is not shown here in this quote is her providers telling her what she should try to do and not do if she delivers a non-viable fetus on the plane, what she should do with the placenta, what she should try to do if she experiences bleeding. This is very dangerous for people. We are also hearing that this is affecting providers in a lot of other areas of medicine that may not be immediately obvious. This is a long quote from someone who is in maternal fetal medicine, who described someone who had a wanted pregnancy through in vitro fertilization. It was a multiple pregnancy. There were conjoined twins that were conjoined in a way that wasn't compatible with life, but they did not think that they could intervene to do a selective fetal reduction for those twins to save the third triplet. And what ended up happening is that because she was unable to get to the far fewer facilities that can do this kind of procedure in pregnancy, she lost the entire pregnancy. So as you have probably heard, there was a leaked opinion from the US Supreme Court indicating that they are poised to overturn Roe versus Wade, and that would leave about half the states in the US with very limited to no access to abortion. This is a graphic from the New York Times indicating which states are likely to be affected. There are states that have trigger bans that were crafted to trigger once the Supreme Court issues its decision. There are bans that have been on the books in these states since before the Roe versus Wade decision was issued back in 1973. And then there are other kinds of bans. For example, Georgia still has a 6-week ban that could go into effect. What this means for Texas, this map just shows Texas highlighted as having a trigger ban. Texas has all kinds of things. So Texas does have a pre-Roe law that criminalizes anyone who provides or aids and abets an abortion. It has a trigger ban that was passed in the 2021 legislative session that criminalizes the provision of abortion except for cases of medical emergency, which, as you can see in those earlier slides, is very hard to define. And that would go into effect 30 days after Roe was overturned. During a special legislative session in 2021, the state also passed a law, SB 4, that criminalizes the mailing of medication abortion pills in Texas. Texas will still have SB 8 that would allow private citizens to file civil charges on anyone suspected of aiding and abetting an illegal abortion. And none of these laws allow exceptions for rape, incest, or fetal anomalies. So I'll wrap it up there and just close by saying, we have been able to look at, use a variety of different research methods to assess the diverse impacts of Texas's abortion restrictions. What we have found in our research is that these restrictions have certainly done nothing to reduce Texans' need for abortion care, but they have reduced access to in-state services and imposed incredible burdens on the people who have been able to travel out of state. These new laws, like SB 8, have also had a chilling effect on not only abortion providers at whom they were directed, but other clinicians who are now reluctant to offer or refer people to essential medical services. And people seeking abortion and clinicians are going to be in even more precarious positions as these increasingly draconian restrictions go into effect. So I will just stop there and get to this question about illegal abortions. Illegal abortions are just inherently very difficult to track and monitor. What we do know from our colleague, Dr. Abigail Aiken, also at UT Austin, is that there are hundreds of people who are requesting medication abortion pills online through a service called Aid Access. We have seen increases in requests for medications online when the executive order was in effect in March and April of 2020. And there was also a very large increase in requests after SB 8 went into effect. So we know that people are seeking medication abortion through that mechanism. There are also lots of other online distributors for medication abortion that do not have systems in place to track how many people are requesting those medications. We know from our past research that people obtain at least misoprostol, one of the other drugs in the medication abortion regimen, from pharmacies in Mexico, either by going there themselves and buying those pills over the counter, or getting them through a network in their community. That is also a very hard practice to track. We are going to be doing some work in some of the border counties in Texas in the coming months to kind of learn not only about what is happening with that, but these are counties that are very underserved in other reproductive health services. And so we're going to be looking kind of at the larger landscape of access to reproductive health care, but including what may or may have not changed with people obtaining medication abortion pills through pharmacies or other networks in those areas where we expect it to be more common. So yes, we know that there probably has been some increases in people getting abortions through these other means. We don't know how much it accounts for the overall number of people who are getting abortions.
We're opening it up for
up for questions.
Yes, thank you. Other questions from the?
Yes.
Questions. So I guess one of the most recent ones that have tried to trace their births, like vasectomies and kind of happening that. I guess I was also interested in disparities kind of by socioeconomic status. When you mentioned like by age, and you also shared like some areas, more rural areas, but I guess I wonder if you know more about them.
Sure. Yeah, so the question was about if we had seen any changes in births following these restrictions going into effect, and whether or not there, what else we might know about disparities and who is or is not getting an abortion or being forced to continue their pregnancy. So we had started doing some other folks on our team had started doing an analysis of birth records, and specifically kind of looking at births among people who delivered through the pregnancy Medicaid, because people who are living on low incomes account for the majority of folks who get abortions in Texas, and are going to be those who have the fewest means to potentially travel out of state to get an abortion. And it was very difficult because of some of these other effects happening in Texas, like with the oil boom and bust, to really, kind of tease out with a lot of certainty what was happening there. Also keep in mind that we saw, just looking at the state data, a 13% decrease in abortions provided in state. We also saw a good number of people going out of state. So yes, there are people who probably continue their pregnancy, but was it going to be enough that we would be able to see this in the birth data? And that might be part of the reason why we weren't necessarily able to see that. With something as seismic, I guess you could say, as SB 8 or a full overturning of Roe versus Wade, and the implementation of these trigger bans and other bans in Texas, we may be able to see more changes in births that are more obvious from the data going forward. In terms of disparities, so again, we do see some impacts on people who are under the age of 18. Disparities in terms of race, ethnicity, or income have been harder for us to get at. And one of those reasons is just the availability of the data. So with respect to income, that's not something that we collect directly from providers. It's also not something providers have to report on their induced termination of pregnancy form that they send to the state. What we do know in some cases is their county of residence or their zip code, which we're exploring some ways to kind of use that as proxy for at least, a proxy for socioeconomic status. Certainly, just because you live in a county that is disadvantaged doesn't necessarily mean that you yourself are, or you could live in a wealthy county and it doesn't necessarily mean that you have wealth yourself. But we are going to try to look at some spatial differences with those indicators. And then race ethnicity, to the extent that that reflects different structural oppressions has also really been hard to get at. Health systems have not done a great job at collecting race and ethnicity data. And it is also something that if they do have it, it is often buried in some other system that is not necessarily easily queryable from their any electronic system that they might have. So as we were planning our kind of rapid data collection, we asked people, can you provide us with race ethnicity data? We want to be able to see like who is able to leave the state versus who might not be able to leave the state. And what we have gotten back has been incomplete. For some providers, it's very easy to get this information, and for other providers, it is not. And so we just don't have good enough data to be able to say too much about that. We have done an early look at the vital statistics data that has been made available from the state of Texas for the first couple months the SB8 has been in effect. And when we did that early look, we didn't see any notable differences in the percentage or the distribution of who was getting abortions in Texas by race ethnicity. What that means, it could just mean that like all of the funding that has been coming in to help support Texans get care has been really effective at making sure as many people are getting care as possible. Yes.
And do you know about the change in the economic cost for people who want to get abortion? Because if I understood correctly, before the HB2, part of it was covered by insurance, and then it's not covered as well. So you have the extra cost and then the cost of travel, right?
Yeah. So the question is about changes in cost with respect to these different laws as well as travel. So HB2 actually did not have any provisions that directly addressed coverage for abortion. That was something that happened in other legislative sessions that prohibited private insurance coverage and marketplace plans from covering abortion. So most people in Texas have been paying out of pocket for their abortion unless they have one of the very few plans that is able to cover it. What has happened with SB8 is something quite interesting, which is there was a concerted effort and by both private donors and larger philanthropic donors to pay for 100% of the cost for anybody who was eligible for care in Texas. And so what this actually has meant is that, and I think this is one of the reasons, a key reason why we saw the decrease in Texas being only 50% versus the 85% that we thought it might be, it's because cost is a huge reason that people delay their care. But if you are showing up at a clinic and you know that the clock is ticking, that today you're eligible, a week from now when you got the money together, you might not be. Having that money there that is going to cover 100% of your cost helps people get in sooner. And there has also been a lot of money that has gone into abortion funds and other organizations that are helping people travel out of state. So certainly not everybody is availing themselves of that, but there are people who probably otherwise could not pay for a flight who are getting money to cover a flight, or they go to Arkansas and there's a snowstorm and they have to stay extra days and they have no clothes, and they can get the cost of those extra hotel days and like a fresh change of clothes that are covered for them. So again, there's still been incredible out-of-pocket costs and economic strain that these laws have put in place. They would be even greater, and abortion would be even less accessible than it already is if there hadn't been this huge influx of funding. Now, we don't necessarily have like hard quantitative data and like sophisticated analysis that we have been able to do around this, but we just know from what we have been hearing from clinics about how things are working on the ground, from abortion funds, from the people that we talk to, that the money matters. Yes.
You've spoken about people going out of state, but do you have any sort of estimate on what percentage of people who are seeking abortions in Texas would leave the country, maybe go to Mexico or fly to Canada or something like that? Is there a way to measure that? Does that data exist?
That data doesn't exist right now, but we are actually hoping in the next couple of weeks, before a final opinion comes from the court, to do some surveys with people who are still getting care in Texas and hopefully a couple of other states, to look at, what if people couldn't get abortions at the clinic that they are at right now, like, would they be able to, or would they consider, getting medications in Mexico? Would they consider flying someplace else? Have they ever flown before? Do they know how to book a flight? Obviously these are hypotheticals, but I think it's going to be the closest to an answer that we might be able to get by asking people for whom they've already gone through a lot of logistics to figure out how to get to this clinic and their concern around their pregnancy, as close as we're probably going to get. But again, what people actually do in those circumstances, we don't know. We interviewed one of the women that we interviewed in the series of 65 in-depth interviews. Drove 7 hours from Houston to Oklahoma, leaving at like 3 a.m. in order to get to her appointment, driving through the dark. If you would have asked her in July instead of October, if she would have driven 7 hours through the middle of the night to get her an abortion, I don't know if she would have said yes, but in October, she said yes. And that's what she did. So, even if we're able to kind of get at some of these estimates, what people actually do in practice, I think is, there will be some variation around that, right? We're not going to know with precision. Yes.
I have one question. There are data on how enforcement, like are people, suppliers, doctors, nurses, whatever, punished or persecuted in some way. So I guess there are like different mechanisms you documented, and some of it is like providers. Some of it is what you, I guess, you refer to as chilling effect. But I wonder how much actual enforcement there is, or is it just like people know this is now the law and they don't do it, they go outside, or are people getting in trouble? Is that also happening? How much is happening with that?
Yeah, so the question is about enforcement and how much we are, how much of this effect is like a chilling effect versus like true enforcement. We don't have specific data on that. From what I would say we have heard from our colleagues is that I think the vast majority of this is a chilling effect, that people are afraid of, whatever legal guidance they've gotten from their hospital. There may already be staff at their, not at the abortion providing facilities, but, staff at their hospital or private practice who are already uncomfortable with abortion, that they may feel may report them if they do anything that is perceived to be in violation of the law. There was I think it was probably weeks after SB 8 went into effect, one of the physicians at a Texas abortion facility wrote an op-ed in the Washington Post saying that he had violated SB 8 by providing an abortion after embryonic cardiac activity had been detected. And what his motivations were for doing that, I am not privy, I don't know what his motivations were for doing that. But if one of them was to prompt a lawsuit, it prompted lawsuits, but not from the people we would have expected. That there were some lawyers in other states that were like, I'm kind of curious how this enforcement mechanism is going to work, so I'll file a lawsuit. But the big groups that have been pushing forward this type of legislation in Texas took his op-ed as a way to try to trigger a lawsuit, and they they weren't going to take the bait. And so we haven't really seen any real enforcement in any, major way happening. It really has been this concern about being saddled with tens of thousands of dollars of fines and, being dragged through the courts. I think that is really, which was one of the intentions of the crafters of this law, was to not have to enforce it, but have it be enforced out of fear. Yes.
Thank you so much for the presentation. I just had a clarifying question. When you wrote that one of the methods of collecting data was a mystery call, does that mean you would call asking for an abortion or to see the wait time, or is that just to get this monthly data, like the?
Yeah, that's a great question. So the question is about, like, kind of what were we trying to get from our mystery calls? And so they are primarily when we started these calls in Texas, they were really to help us track like which facilities were open, how long was the wait time to get in for an appointment. So we have undergraduate research assistants and staff on our team who, do these calls on a monthly basis, and they call as someone who's seeking abortion and they're looking for information. They have a date of their last menstrual period. They're asking, like, do you provide medication abortion? Do you provide procedure abortion? Like, when is the next appointment and how much does it cost? And then they never book an appointment. They're just calling for information. And so we also began doing these calls after SB 8 went into effect at out-of-state facilities, primarily just to see what the wait times were, because we were really anticipating that the waits were going to increase for appointments, and that is indeed what we saw, is that it's taking where before someone could get in the same week, now it's taking 2-3 weeks or longer to get in. So it's mostly kind of wait times and methods that are available.
The same time per month, I guess.
Yeah, so we call the same time every month, so that we're consistent and getting clinics at the same point. Oh yes, thanks. Sorry, the light like kind of blocks you from.
Thank you for this talk. I'm curious if you could speak a little bit to sort of how you're thinking about as tech step, sort of in this new moment, evidence and data might matter. To think about sort of as we lose potentially Roe, like what data and evidence can do in this moment, and sort of how that shifts your strategy, if at all. Yeah,
that is a great question. The question is about like what evidence and data might matter. And I think that I've been in a variety of conversations over the last few months, some of which are like, well, data has gotten us nowhere. It hasn't helped us stop these laws from going into effect. We don't need to spend more money on collecting data, which as a researcher, of course, is like an existential threat. And also something that I don't believe is true. I think we will do worse if we are in a data void, that we need to know what is happening. And I like to think about, there was a team of epidemiologists and other researchers working out of the CDC right around the time that Roe versus Wade was decided, who began looking at what happened with mortality and morbidity from abortion after that law was in effect. They could have sat back and said, well, abortion is legal, we don't need any more information. But instead they said, like, we need to see what happens here. And through that analysis, they were able to learn about what methods of abortion were safer. And we have a lot of great data now because of that, kind of epidemiological effort. And I think as we are sitting in this position right now, again, if the Supreme Court does issue a final decision that overturns Roe versus Wade, and we get to a place where half the states lose access, or depending on how the elections go in the fall, if there's eventually a move forward for a national ban on abortion, that, you know, we need to know what is happening. We need to know what is happening with pregnancy outcomes and certainly maternal mortality. But it's not just people dying, it's the people like the woman that we interviewed who are, you know, having really terrible complications from their pregnancy because their providers cannot offer evidence-based care. It's learning about like what are the health and economic outcomes for people who are forced to continue their pregnancies, who survived their pregnancies. It is on, you know, just the, you know, there are so many other things that we need to be looking at. You know, what are the implications for rolling back access to contraception or making sure that those systems are as robust as they can be? Not that that is going to, you know, there is never going to be a time where people do not need abortions. History has shown us that, but you can help people get access, ready access to great contraception. And we need that as well as we need this other information. But I think we need to be able to track what is happening because while I think that if we lose access, there is a long time that access will be lost, I think that we need the evidence for a time in the future where we can reestablish the right to abortion in the US, and we need to have the data behind it. Yes.
It seems like online providers like aid access are going to be really vital in the coming months. And I'm wondering, thinking about if you do an SB4, it would specifically criminalize mailing medications, if that sort of legislation would impact a service like aid access or any other threats that you see that are trying to crack down on that.
So the question is, are, you know, with online shipments of medication abortion pills, would laws like SB4, you know, kind of get in the way or affect access in some way? So the real challenge here is, how do you enforce those laws? And, you know, through some other conversations I've had with folks over the last 24 hours, you know, we currently do not have an Anthony Comstock in the US Postal Service that is rifling through people's mail looking for obscenities or looking for abortion pills. Whether or not that will be something of the future, you know, one only knows, but it is a really hard thing to track. You know, I think that this is a piece of legislation that was put forward with a goal to really go after aid access and really pose a threat. And I don't think that that it has worked in that way. You know, certainly the other shippers of these medications probably know nothing about SB4, and so they're continuing to mail the medications. So I don't necessarily know that it's affected the distribution side. Is it going to affect the people who are getting the medications just because of, you know, somehow that this could be tracked? We don't know. The other challenge, though, that is posed here is, you know, if providers in other states who do not have a medical license in Texas can provide telemedicine and then mail those medications from a US pharmacy to someone in a state like Texas or Mississippi or another state that's likely to prohibit abortion and could also impose a law like SB4. And that is, you know, we don't really know how that will play out. I mean, it is possible that there could be some legal mechanism to go after these providers. And, you know, certainly if they physically cross state lines into a state where they have been prescribing medications. But we don't know how that is going to look. But I think certainly there are physicians who, if they're thinking about it, they're also thinking about the legal liabilities and, you know, potential risk to their medical license and things like that for doing it.
Question. Well, one point I guess was around the criminalization or enforcement, and there was, right, the woman who was taken to jail, if I'm not mistaken, for purportedly causing a miscarriage. right? So that was in the media and also contributes to this chilling effect. I think she was later released.
Yes, so there was a case of a woman in South Texas who who was pregnant or recently pregnant, who presented for care in an emergency room in South Texas and was arrested and jailed on a very high dollar fine or bail. I don't remember the dollar amount, but it was just really an inconceivably high amount that, you know, a regular person, let alone someone living in South Texas, would be able to afford. And eventually, through a lot of media attention and other efforts, she was released within a couple of days. You know, there are, just to quickly say one more thing and I'll let you get to your question. There are very few, if any, states that really have laws on the books that specifically criminalize someone or say that it is a crime for someone to end their pregnancy on their own. And there are also lots of other laws on the books that states have used to press charges against pregnant women, like in Alabama, where I used to live before I moved back to Texas. They had a child endangerment policy that was really aimed at people making meth in their house. And what they ended up doing with it is using it to prosecute women who were using substances while they were pregnant. So anyway, you had a question though.
I just was curious. I mean, it was good to see that there weren't any clinic closures thus far. I guess I'm just curious in terms of the providers and like the workforce and sort of where people are right now in thinking of like their livelihoods, right, and what they've trained so long for, as also just in the midst of wanting to provide this necessary care when it's under threat. So I guess it's not really a question, but I guess I just would be interested in hearing what you've heard and how people might be contemplating that.
Yeah. So the question was about, you know, kind of what is kind of like word on the street around how providers are thinking about what they're going to do or given the current circumstances and potentially worsening circumstances and in terms of continuing to deliver care. So I've heard a couple of different things. I mean, there are some providers who have that are considering at least, you know, not continuing to practice in Texas. They may practice in another state. And as one of my colleagues said, you're not stopping people from providing abortions. They're just going to be providing those abortions in another state. You know, there's also, you know, some people have jobs that, you know, part of their job is providing abortion care, and part of their job is, you know, working at a hospital. And, you know, it's unclear how clinics are going to shift the abortion providing facilities are going to shift their mode of practice, or if abortion is fully banned in a state like Texas. Some places are thinking about ways to, you know, help continue to stay open and provide some basic level of services that will facilitate someone getting their abortion in another state. You know, how financially sustainable is that kind of model? I don't know, but they may, you know, some places may be able to do that with a combination of other services that they provide. You know, the other concern, I think, too, are, you know, what is, you know, what also happens not only to the physicians, but also the other folks who work at the clinics, right, who are nursing staff, medical assistants, who are working the front desk. You know, is it going to be possible to support this same full team the way that they have been thus far? You know, while some doctors may be able to go get a medical license to work in Colorado or New Mexico, you know, it may not be possible for these other folks who have been working at the clinic to have the same, you know, they may not be able or willing to do that because of, other things going on in their lives. And so, I think that there's just a lot of uncertainty right now that is also taking a real psychic toll on folks working in abortion care right now in these states. Yes.
One last question. I think, I'm not sure if you said anything about this, and I missed it, but kind of what is the public's opinion and how has this evolved in Texas with this kind of legislation? So are these legislations kind of reflecting strongly kind of the public sentiment or have special interest groups that are very powerful, or do you have a sense of how that breaks down and whether that has changed in times?
Yeah, so the question was about, the extent to which these laws reflect public opinion. And I think there's both, data from Texas, data that other large polling groups like Pew and Gallup have done that indicate that, most Americans or people that they poll do not support overturning Roe versus Wade, contrary to what may have been indicated in Justice Alito's draft opinion. In Texas, there was a poll that came out in April of 2022 on whether or not Texans think, I can't remember if the question was if they think Roe should be overturned or if they, think abortion should be illegal in the state. And the majority of Texans said no. And, there are divisions along party lines, of course, but it isn't a 0% among Texas Republicans. There is still a sizable percentage. I don't remember what it was. It's maybe less than 50%, but it's definitely not zero of Texas Republicans who do not think abortion should be illegal or Roe v. Wade should be overturned, whatever the question was. It is, obviously there are some different viewpoints, but there are still a large number of people in states like Texas who think that people should still be able to get access to abortion. So these policies are really, I think, reflective of groups who are pushing forward legislation, who have access to policymakers, and because of changes in how districts are created and whose vote counts and by how much it counts or if it gets thrown out, I think it's more reflective of those processes than necessarily the greater public's views.
Well, we're just about at time, so I think we need to end. But thank you so much. So informative, really interesting, and so important for us to have all this information right now. So thank you.
Great. Thank you so much for having me.